It's so nice to see you all, and again, thanks for the invitation. It's really great honor. It's amazing. The last time I was at SAC was, oh my God, 2013, and we were in Bern, and here we go, like almost 10 years after. Get the invitation. It's very humbling, very honoring, and I'm so happy to see all of you and connect with good old friends and see you all. So I will take the permission if you'd like me to share my screen. Whenever you're ready, I'm ready.
No, of course, go ahead. So we're really ready to hear you talk. So it's just like to give a little bit background because we are two board. We have the HCC, which is really evolving and it's really happening a lot in the field. And we try to really come down and give good recommendations for our patients. But this is becoming more difficult, and that's why we need some intellectual insights from you, and that we can also discuss what we are going to do with the patients, especially if they are in the field of the carcinoma stage B and C, which are quite common. So thank you very much for joining. We will discuss afterwards how we're going to proceed, and also the latest data which will come then, which have to be also incorporated. Thank you very much for joining, and we are very curious to hear you talk.
Well, thank you very much again. It's really a great honor, as I just mentioned, and really so nice. And I totally agree that HCC is becoming a more even hot item than it was to begin with. And it's a great delight to be with you to discuss that. These are what we're going to talk about on the agenda today. You'll notice some of them are not necessarily pertinent directly to what we really are keen and tasked on regard to the local and systemic therapy. But I thought it will be very important to bring them in because there are some components of them that will be very important to help us bring into the discussion point of things that are valuable and how can we really evolve into the novel therapeutics or even future clinical trials. So number one, I'll start with the etiology or risk factor for liver cancer. And no doubt that the same risk factors that we have heard and learned about and talk about for the last 20 years are still the same. Hepatitis B, hepatitis C, alcohol liver cirrhosis, and alcoholic steatohepatitis are exactly the same. However, what has happened now, and we have to be very thoughtful and conscious of, is that the number of patients with non-alcoholic steatohepatitis, i.e. morbid obesity and diabetes, is on the rise, and guess what? All over the world. This is a very famous paper, highly recommended to look into from New England almost 20 years ago by Dr. Kali from Emory, and looked at so that the percentage risk of dying from cancer independent of anything else is connected with morbid obesity. As you can see, all cancers are represented, but fascinating that liver cancer all the way at the bottom, 5% risk of dying from liver cancer simply by the mere fact that the body mass index is more than 35. Oops. So this clearly is an important awakening call for all of us to be thoughtful of. And the misperception that many of us had that morbid obesity happened only in the Western Hemisphere is absolutely wrong. Actually, morbid obesity, because of the lifestyle of all of humanity, because of the food that we are consuming as a whole humanity, is changing wherever we are. And in other words, are we hearing from our colleagues in Asia about morbid obesity? Of course. Are we hearing from our colleagues in Africa about morbid obesity? Of course. And of course, add to the Western Hemisphere as well. So sadly, it's everywhere. And I will not be surprised in no time that the morbid obesity is going to bypass all other risk factors for the development of liver cancer. And we talk about morbid obesity, understand we're talking about like central obesity, which of course has a genetic factorial component add to the metabolic components that can lead to it. Research on it is evolving, and at some point in time, we might really get clues that help us how to treat patients, but they are not there yet. And this is an important kind of prelim to what I'm going to talk about a little bit later on, which is the issue of the response to checkpoint inhibitors based on the etiology, if there's any pertinence or not. We'll talk about that. So I jump on right away to the issue of biopsy. And if anything, funny enough that I prepared that lecture several weeks ago since the invitation, and it's amazing that this exact same question just happened like a few hours ago. I was called by one of my colleagues telling me about the patient, you know, good, okay functionality, however, relatively on the older age, and keen on getting therapy, but the family is not very keen on getting the biopsy. And I personally, my answer was, no, we cannot do that. And the reason is because, here we go, this is probably good representation. All those radiologic diagnostics that we talk about will apply only if there is cirrhosis, i.e. if there's no cirrhosis, they do not apply. And interestingly, then come to the question, what is cirrhosis? How do you diagnose cirrhosis? My answer is, I have no idea. Because number one is it a radiologic evaluation as the group from Barcelona thought of 20 years ago? Maybe not. Is it by blood work? Maybe. Is it by some of those novel therapeutic, including some of the scanning? Possible. But ultimately, it has a lot of kind of, you know, subjective component that we don't have full clarity regarding what it means. And not only that, but with this, the LIRAD, which is a radiologic assessment that will help us evaluate exactly the extent of disease, is very dependent on that cirrhosis component. In other words, this will all not apply if there's no cirrhosis. Now, interestingly, on top of that, the LIRAD, and this is an important point for all of us, is not foolproof. It's not guaranteed that's it. If it's LIRAD 5, it means 100% it's HCC. I can assure you that nobody will be ready to, and I know litigation is not really what really governs activities in Switzerland, but here in the US, you know, it's a big item that people always care about, being patients or physicians. Interestingly, can any of us be ready to say and depose saying that this is HCC based on LIRAD? I'm not sure, because as we can see over here, the LIRAD diagnosis of small HCC can never be 100%, even though it can really suggest them for about close to 90+%. But on the other hand, for those kind of limited percentages, could this be, for example, a combination of two diseases like cholangio plus HCC? Could be cholangio only, could be something else. Of course, it remains on the table. For that reason, we still strongly vouch for a biopsy, not only that we need it for diagnostic purposes, among which, for example, as we said, 15% chance of getting combined HCC cholangio, but on top of that, we need to understand the genetics of the disease. This is some of the work that we did at Sloan Kettering. Proudly, we did try to delineate at least 3 pathways through which HCC can develop. But as you can see, the information is subtle. And the reason is because we don't have that much already that we know about the disease based on the biology. So please, I urge you, and SAC is very capable of, any potential clinical trial that you want to do is very critical to make sure to have tissue, same all the trials that we've been involved in would. And number 2 is make sure that you do the genetic analysis that's applicable to make sure we understand better what's going on. So with this said, I'm coming to a third important component as an introduction before I get to therapy, which is scoring and staging. And interestingly, this is an effort that we have done here at Sloan Kettering a while ago, looking at the patients with liver cancer, pathologically diagnosed, with a component of an etiology of certain nature, and stage 4 disease and need for systemic therapy. We did try to delineate those patients in at least 8 different scoring systems, as you can see over here. And as you can see, some of those scoring systems are more complex than others. If anything, those green dots imply this specific parameter that you can see to the extreme left does apply. And as you can see, some of them have a lot of parameters above and below the green line. The green line pertains to whatever is above it is related to the liver function, Whatever is below it is related to the liver cancer itself. And as you can see, some of the staging systems are pretty complex, will require many variables, and some are a little bit limited in regard to how much they do. Regardless, we went ahead and evaluated them all together, and we found that actually the CLIP and QP system are best, but to be fair, Child-Pugh was acceptably okay, and that's why, despite this was evaluated and required to be done as per the effort that was, just happened haphazardly in the last of the EASL meeting, the Eastern European liver cancer meeting, or the EAS of the liver. I would say that it's acceptable. It will work because remember, now we have data from all those clinical trials, which tells us that we can depend on. However, the Child-Pugh, as it's becoming, we're dependent on it, we have to remember the following. The Child-Pugh, number one, is more of a dynamic parameter that can move over time and evolve based on the intensity of each one of those 5 parameters. And as such, I always probably like to describe it as follows. It's not, jokingly, it's not an ice cream flavor. It's not like this patient is A, that patient is B, maybe this one is C. It's not like by choice. Actually, it's only A that goes to B, that goes to C. And interestingly, this is not a linear curve. It's not like A to B to C at the same rate. If anything, the curve is like this. A is a long, 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 long line from here where I am in New York to where you are, wherever you are in Switzerland, in Bern and Zurich, etc. That same long straight line will turn around the earth, go back to New York, and still a long line. B is a curve and C is a shoot. And that's why it's very important for us to always catch patient in Child-Pugh score A, because this is really where you can help them best. And then we hope that things don't worsen at some point in time in regard to their disease at all. So with this kind of understanding of the Child-Pugh and the keenness of having the Child-Pugh A patients to be treated, I'll pause and I'll move on to the locally advanced disease therapy, and then we'll talk about the first-line treatment, and then I'll touch on with etiology and impact. So, in regard to locally advanced disease, the story evolved very quickly because historically, if you recall, there's the arterial embolization study that was done by Jose Plové almost 20 years ago, actually exactly 20 years ago. It was on May 18, 2002. My God, time flies. And at that time, you remember, we all got sold in. You give an embolization, median survival 3 years. We're very happy about it. We're excited. And we even misperceive that maybe it can cure patients. Interestingly, in that specific study from the Lancet, if you look, and this study is already in the publication, actually, I did that exercise. If you pull out from the article itself, what was the size of those tumors that were embolized? You can see it all the way at the bottom of the table in the last row. The median size was about 50 millimeter or 5 centimeter. That's it. Interestingly, all of us, without an exception, we continue to say median survival from the embolization is 3 years, but we never really refer to the 5 centimeter limit. At the same time, despite that, we are very comfortable. We treat way bigger tumors than 5 centimeter, and we'll still say median survival 3 years. Here at Memorial, we did an exercise, which, by the way, it's not the purpose why I'm showing it, but it's still valuable for that same purpose. We did compare bland embolization to chemo embolization. There was no difference. And again, as I said, it's not the purpose why I'm showing this. But as you can see here, if you look at the bottom row, the median size of the tumor this time is 8 centimeters. It's not anymore the 7 centimeter we spoke about beforehand. And that's exactly what I'm trying to really imply here, because we are talking about relatively newer data, only from about 5 or 6 years ago in 2016. And interestingly, yes, exactly as I mentioned, there was no difference at all between bland embolization we can see in the curves versus the chemoembolization that also we see, the blue and yellow curves, they are totally hugging each other. But if you look at the bottom line, the median survival is 20 months. That's it. This is all what embolization can do, 20 months, based on what we're giving at the moment in regard to therapy, and considering that these tumors can be rather larger than the classic 5 centimeters that we knew about to begin with. So that exercise was kind of like really looked at very carefully by Kudo and colleagues from Japan. And that's rather intriguing. They came with an interesting formula, which already to some extent is used by some of the transplant doctors. And they said, we are going to look at what's called the up to 7 criteria. What's the up to 7 criteria? You take 2 numbers. You look at the liver, see how many lesions there is in the liver. Let's say 4. So you take the number 4. And let's say the largest lesion in the liver, let's say is 4 centimeters. So 4 plus 4 equal 8. 8 is more than 7. As you can see on that table, anything which is in the blue could be even resectable or applicable to radiofrequency ablation, which can be curable. Anything in the green, which is amenable to embolization, do very well because these are the patients that fit in below the up to 7 criteria. The minute you hit into more than the up to 7 criteria, you get into the green, the yellow, and the red or pinkish color. And this is really where the issues can start becoming a problem, where embolization might not necessarily help patient best. If anything, this is a study that he did. I would say it's a little bit daring, but nonetheless, it was done in the Publishing Cancers Basel. And it shows very clearly that patients were randomized when they have more than the up to 7 criteria to either lenvatinib, it doesn't matter which one, but it's a tyrosine kinase inhibitor, lenvatinib here, versus chemoembolization. And as you can see, number 1, the median survival for the chemoembolization was 21 months, exactly like the 20 months I just mentioned a second ago from Sloan Kettering. While impressively, the lenvatinib median survival for those patients with locally advanced disease with a Child-Pugh score A, but beyond up to 7 criteria, is 37.9 months. Wow. So they live way longer than even embolization per se. Not only that, but also Dr. Kudo was able to show that actually their ALBI score as a variable for liver functionality, in the blue, you can see it for lenvatinib remains relatively steady, but interesting in the red, you can see it for TACE continue to progress to grade 2 from grade 1, which means worsening liver function per se. So I would say that this really opened the opportunity for more of that collegial, multidisciplinary team approach that we need to ensure that we treat patients correctly. In addition to that, however, does not take away the need for the consideration or study of the combined therapy per se. And I know we tried many things with sorafenib plus chemoembolization, did not work. There is another one, which is the Launch Study, which is kind of like presented over here, which is looking into lenvatinib plus TACE. By all means, I would say interesting that we're bringing that question still. But however, also, we should not forget about the checkpoint inhibitors, as we know about many studies, among which the Emerald studies and many others, that's looking into if the tumor immune microenvironment of the HCC can further enhance with the use of the embolization, the value of the checkpoint inhibitors. Something that to be proven, but definitely worth looking into as well. So, with this said, by the way, to carry on in regard to the study of the lenvatinib plus TACE, we can see over here that yes, there has been some suggestive improvement in outcome, as you can see over here with improvements of about 17.8 months versus 11.5 for the lenvatinib per se, and at the same time, same thing for the PFS. Now you just wonder, is it really that we kind of like have to really bring in here a embolization approach as a comparator or a systemic approach as a comparator? That's definitely, it all depends what are you trying to do. Are you theoretically bringing BCLC-B therapy to BCLC-C or vice versa? something that definitely worth looking into further. But at least I'm happy to see at least some suggestive work that yes, combination therapy might be valuable. So with this said, and with this kind of like exercise reassuring us one more time about the clear kind of connectivity between the local and systemic therapy, I jump on to look into first-line systemic therapy treatments that could, of course, influence both systemic and local treatments as well. So, of course, we all got excited, and this is great data that happened last year, the Umbruch 150, looking at atezolizumab plus bevacizumab, with a clear improvement in survival, as you can see clearly over here for the atezolizumab plus bevacizumab, 19.2 months on the updated revision of the data versus the 13.2 month for the SURAF. Great data, great positive study. But as we all know, a positive study bring them answers, but also bring many questions. And what are the questions that bring up with you Umbruch 150? Of course, is it the only one? Probably not. The Himalaya actually that I was humbled and proud to present on behalf of all colleagues from all over the world at GI ASCO a few months ago in San Francisco, looked into, interestingly this time, 2 checkpoint inhibitors, tremelimumab. Interestingly, it's one dose only of the drug plus durvalumab, with again, we see clear improvement in survival, 16.4 months versus for the T300 plus D versus 13.8 for the sorafenib, clinically and statistically significant. So what exactly is going on? No doubt this is all coming from the immune cycle. And as you can see over here at point number 7, you can see how the activity at the cell membrane level is very critical and impactful in regard to this anti-PD-1 activity to occur, where now the T cells are allowed to touch on the cell, cancer cell surfaces or membranes. But interestingly, now we know this does not happen without an invitation from a chain of command order that come high up in the chain of command, like, for example, at point number 5, the anti-VEGF that we see, or as we saw in the Himalaya at point number 1 in the lymph node itself with the anti-CTLA4. And of course, as we all know biologically, the higher you are in the chain of command in regard to control of the outcome, the better you are in regard to the outcome per se. And as such, what we saw with the Himalaya study is probably dependent on that very important graphic. CD28 in the lymph node talk to CD886. Think about it as if they drink like some very strong coffee and they send the message all the way down to the cell membrane level to exert their effect. Interestingly, however, CTLA4 come into play, and I don't know, they convinced CD86 to kind of enjoy some very good Swiss beer, and they all kind of like ultimately do so much of it, enough they fall asleep, enough that they can do the job. This is where anti-CTLA4 come into play, pull away CTLA4, let CD86 exert their effect. By the way, all what I just described in kind of this graphic way, this was the Nobel Prize in 2019 of Jim Allison and colleagues about CTLA4 and how you can inhibit it with further enhancement of the anti-tumor activity at the with the help of anti-PD-1, anti-PD-L1. So, interestingly, as such, to go back to the Himalaya, this really probably described it best. Interestingly, anti-CTLA4, you don't need that much. As you can see over here, think about it as a jump starter for the car. You jump start the car, the battery, and then you push on the gas and the car keep going. And as such, the one dose only is more than needed. Not only that, but interestingly, that kind of CD28, as you see, I put the circle in green, which is very small, which is the activation. The anti-CTLA4, I put it as a big circle, not because I have space on the slide, but because, fascinating, the anti-CTLA4 activity is 3 times more potent than the natural occurrence of CD28 in the cells. Amazing. And as such, that's why the one dose is more than needed, especially as we all know, we're not excited quite a bit about the anti-CTLA4 as a therapy to give on a regular basis because of the potential side effects and toxicity. So the Himalaya kind of bring in, and remember in the beginning, I mentioned that the issue of like, who are those patients? This is a tumor response. We can see that, yes, there has been some responses in regard to the disease. There has been some even complete responses, subtle, but nonetheless there. But interestingly, there's something very intriguing, which is that the time to response was very limited, barely 2 months. And this really kind of tell you that T cells are primed and they take time to be fully primed, but some of them are primed in the beginning enough to cause effect immediately onto the tumor. And this, of course, compares to the sorafenib. No doubt that the sorafenib has been our standard for a long while now, almost 15 plus years. And really, it was based on the Himalaya study, on the SHARP trial that really showed the improvement in survival. We all got excited. And of course, we kind of like very keen on giving patients sorafenib, despite that we were not happy about the side effects per se. Interestingly, then lenvatinib came into play. Now, that really brings a pause because smartly enough, whoever decided to work on lenvatinib, and I think it was Kuda and Finn, said, well, it's a tyrosine kinase inhibitor. We don't think it's going to do any better than sorafenib. Almost like as if they are saying the racetrack is one specific length and you cannot make it any longer. So we're going to compare them for non-inferiority. And non-inferiority studies are well described in the literature, and I'm sure your group has done some of that same nature before. And by all means, a non-inferiority implies that we can really give the therapy and just look that, make sure it's not worse than the standard of care per se. Interestingly though, can I, while I'm doing the non-inferiority, look into if there's any further advantage of it, i.e. even though I'm running for the same length racetrack, can I have a faster car? And yes, you can. If anything, lenvatinib has close to 3 times more potency in regard to the PFS compared to the sorafenib per se. And by the way, go back to the durvalumab. This was another exercise of non-inferiority. It was compared for non-inferiority versus sorafenib in the Himalaya, and there was no difference at all. And maybe some subtle difference happened at the end of the tail of the curve, because as we know, we just spoke about the priming of the T cells takes a while, might have benefit the patient later on, more than the sorafenib. So if anything, yes, combination therapy with checkpoint inhibitors is critical. TKIs, yes, and sometimes are applicable. Sorafenib, lenvatinib does not matter, but we know these days that we are a little bit more kind of seeing that patients are more tolerant to the lenvatinib. And of course, single agent checkpoint inhibitors like anti-PD-1 and PD-L1, as we're seeing in durvalumab and sorafenib, are equal and will not be giving more than what a TKI can do by themselves. So now that I summarized the first-line treatment, and I'm confined only to first-line treatment, I'm going to touch on a very important etiologic impact component, which can be a great invitation for SAC and other groups to look into when we do correlative components of clinical trials. The Himalaya was a very global study. On purpose, I'm putting the slide to really show the globality of the study. And you see literally everywhere was well represented in regard to the disease, wherever it is. And interestingly, same thing happened in many studies, among which the Keynote 240 that looked at the pembrolizumab versus placebo. And we can see here, there was barely any difference, even though ultimately there was acceptable, non-statistically significant difference, enough that the pembrolizumab was approved in second line. But as you can see over here, despite that in the whole study, the population did not differ in regard to the outcome, 13.9 months for pembro and 10.6 for placebo. But on the other hand, if you look into Keynote 394 that occurred in Asia, you can see that over here, the pembrolizumab is 14.6 months, while the placebo is 13, with some further significance in regard to outcome. So, wow, how did this happen? We just did the study worldwide, not much occurred, and now we're doing it only in Asia. There's a little bit of improvement in outcome. Not only that, but actually a combination of the two studies together and do a meta-analysis show that, yes, maybe now, as if the 394 is pushing further up the benefit of the 240 with 14.2 months versus 12.5 for placebo. A little bit perplexing, but if anything, this probably can be answered also from the Himalaya as well. Because in the Himalaya, as you can see, if we look at the fourth row in the first on the left in regard to viral etiology, we can see that 1/3 of patients Hep B, 1/3 were Hep C, and about 40% were non-viral, i.e. alcohol or NASH. And to be fair, I think we all agree this is a very good and appropriate representation about what's happening worldwide. And however, if we look at the Ambrave 150, and one more time look at the etiology, which is all the way at the bottom, you can see that 50% of the patients have Hep B. So now again, to repeat, we have the Himalaya, which is 1/3 Hep B, 1/3 Hep C, 140% are non-viral. Here we have 50% with Hep B for the Ambrave 150. And add to this, we showed data on the Keynote 349 and Keynote 240, showing that patients with Hep B seem to fare better in regard to the checkpoint inhibitors. Well, this is very true, because if anything, we have noticed, and these are hazard ratios that already are reported publicly. For the Himalaya, the hazard ratio for the patient who received the therapy and are Hep B was 0.64. For the Hep C was 0.89, and for the non-viral 0.79. So clearly, in other words, the Hep B patients fare best, but to be fair, does not mean the others do not benefit. Everybody does benefit, but clearly the Hep B patients might benefit the most. Now, this brings two important things. Number one, on the practical level, this is a reminder that we should not compare apples and oranges. We should look at the demographics of the study specific before we say, well, maybe Ambrave 150 is better than Himalaya. No, to be fair, they are totally different. We saw that 50% of the patients in the Ambrave 150 are Hep B, while only 30% are in Hep B in the Himalaya. But more importantly, number two is, what can we do with that data? And that data, as we see, and this is one more prelude to show that when we look into the Asian population by itself, we can see now not only improvement in outcome for the Hep B, but actually clinical significance. This is how we turned a study for the Keynote 240, which was totally negative. If we take the Asian population only, it reconfirmed the Hep B patient 13.8 versus 8.3 with the hazard 0.55. So what can we do with this? We can do a lot of things. Number one, we all got excited about the Pfister study that many of you already have seen. That, to be fair, it was intended to be preclinical work, but nonetheless, they look at that time at the studies that are available, among which the 240 that we just spoke about and the Ambrave 150 that also we spoke about, and add to the Checkmate 459. And they have seen that, yes, maybe Hep B and Hep C patients might fare the best, but doesn't mean the non-viral don't fare that well, but maybe to a little bit lesser extent than the Hep B and Hep C. The question is why? It seems that after all, the variables for those therapies are not really as simple as we thought it might be. As you can see over here, HCC that we thought originally was driven by only etiologies like Hep B, Hep C, NASH, and non-alcoholic fatty liver and alcoholic fatty liver disease, it appears to be that the variables are way more than that. We still have Hep B, Hep C, you can see it to the extreme left, but we have CD4, CD8, FOXP3 expression, myeloid expressions, CTLA4, Ki67, PD1, PDL1. And this is, by the way, only 8 variables, and we didn't even talk about everything else yet. This is, by the way, an invitation. We currently are proudly doing work worldwide. We have cohorts of patients from different parts of the world, including Asia. We have representation from Korea. We have representation from Europe, represented by France for this one. We have representation from the US. We even have mixed representation in the US, add to also a Pacific Islanders from Hawaii. And we are now acquiring another sample collection from India as well. Why this is important? Because we're trying to look into the RNA details and look into who are the patients that can benefit from therapy based on those variables that I'm showing over here that can tell me who should get the checkpoint inhibitors, who should not, or if there's any variation to the checkpoint inhibitor, and ultimately can we change the therapy from being a random guess, as it was always for chemotherapy and still is, to something more of, you have this, you get that, and we give the patient the right therapy per se. So with this said, I spent about like half an hour or so talking about things. I'm going to stop here, and this will give us plenty of time to discuss what I presented, or of course, anything else you'd like to bring up related to HCC. I think again.
Awesome. Thank you very much.
Thank you.
There are lots of questions. I have two co-moderators here. I'll hand over to them. So this is Joachim Mertens, he's a gastroenterologist and also interested in HCC a lot. He did a lot of treatment of this patient and also some research, I guess. Over to you. And then we have Oliver, who is an interventionologist.
Thank you very much. Thank you, Ghassan. I'm also a hepatologist, probably more at this place here. But I have a question. Your clinical practice, how much does the actual underlying liver disease or the etiology of liver disease really play a role in choosing the therapy? We were lucky enough to be kind of the clinical part in a very basic research study that was published in Nature last year by Matthias Heickenwälder and colleagues, where they seem to show that, for example, Nash patients really respond much worse, or Nash cells may respond much worse to immunotherapy than other entities. So I'm always questioning this, and we've actually, in our tumor boards, then started to think about should we really treat that NAFLD HCC with immunotherapy or rather something else. So is this something that you actually consider today?
No, thank you so much. This is a very important point, which is pertinent to exactly what we just brought up in our discussion and what I just showed some slides on. I would say that our take has been that so far we don't have any practical and firm evidence that we should not get the checkpoint inhibitor therapy to specific patients, for example, the non-viral. Interestingly, even in the Pfister data that really kind of triggered all of this together, to be fair, the Pfister data in the Nature was a study that was more destined to look into preclinical basic science work. They did a rather interesting effort to look into the clinical data, but they did not necessarily imply their finding to the clinical data to give them credit. Interestingly, if you look very carefully in that study, at some point in it, they talk about, well, we assume that there are certain type of exhausted CD8 cells that really will affect this kind of different outcome between the viral versus non-viral. Well, guess what? And you can look this in the literature already published. The exhausted CD8 are the ones that actually drive hepatitis B viral infection. So how does this kind of like happen? Interestingly, because there's one word in that paper of Pfister which really say it all. They said they did not, to give them credit again, they said very clearly, we did not define those CD8 cells, because of course they can come in different flavors, could be different cells, and as such, really, they have an observation in the preclinical work. They have a certain presumed correlation to it in the clinical work, but to be fair, they don't have full description of those exhausted CD8 cells. And as such, I don't think with those kind of three findings from that paper alone are enough to what you just brought in, Dr. Matthias' data as well. I don't think we have enough to really say for a patient with non-viral, by the way, we're not going to be able to give you checkpoint inhibitors because we of no use. Because as you saw, even for the Himalaya study, the hazard ratio for the non-viral was even better than it was for the Hep C. So for sure, the therapy will still apply.
So I'm the interventional radiologist, and of course I know that you also have a very active unit of IR in Memorial Sloan Kettering, and so I would be very interested in how you interdisciplinary decide on how to combine treatments of local regional treatments and systemic treatments. And well, if you look at the data out there, there are only scarce randomized controlled trials comparing most of the time it's radioimmunization plus sorafenib as compared to sorafenib alone. And the trial, in the end, it failed. And there was only, in the subgroup analysis, there was a benefit of patients who had non-cirrhotic liver disease, which goes in the direction of the etiology topic, and to differentiate them according to the etiology of what to do with the patients. And now we have the Launch trial, which combines a chemoembolization with imatinib. Are you discussing that at the moment with your colleagues in patients with stage B who are beyond the 7 criteria, or even in patients with stage C, that you combine those upfront?
Well, thank you very much for the question, and I like this question. And you're hitting on a critical component, which frankly is a very dear component to our hearts here at Sloan Kettering. 4 points that I would like to bring up, which are 4 points kind of like alluded in the question. Number one, by all means, is very critical, and I think you're already suggesting it, and I totally agree with you, and I'm glad that we do it the same way. Team work and multidisciplinary team discussion and tumor board are very critical, because this is the only way that we avoid having a patient that's hugged on only to one therapy per se, but rather giving the opportunity to be evaluated and discussed in every treatment discussion that can happen. Point number 2 is the first experience in regard to the TACE plus sorafenib was for sure, as we all know, not necessarily enticing. It was not really positive, but to be fair, it taught us a lot. And interestingly, you're going to be surprised at this. When MedImmune came to me back in 2014 or 2013, at that time, I just remember, because before MedImmune was bought into AstraZeneca, they presented the first data that actually was evaluating the anti-CTLA-4 in patients with Hep C. And this happened, you remember, in Spain. And Alejandro at that time did it in Spain. Actually, my first comment was this therapy will work best in an environment where you alter the T cells and lymphocytes, and this will be an embolization. Actually, my first recommendation was don't even bother with systemic therapy for the checkpoint inhibitors. Go for embolization plus the tyrosine plus the checkpoint inhibitors. So no doubt that it's a very dear subject to us. I know it's not necessarily fully public, but at some point you'll hear about that we're leading, or rather co-leading with colleagues from Asia, a novel study that will look into the use of a triplet of chemotherapy plus checkpoint inhibitors, or rather chemoembolization correction plus checkpoint inhibitors plus type C kinase inhibitors. Because no doubt that you're right, further enhancement for the critical chemoembolization with other target therapy that can help enhance the effect that either impacted by the tumor itself, or to be fair, the alterations that are caused by the effective embolization can add on to the tumor, will be very critical to address at the same time. So we'll see how this is going to go. Of course, it might change the therapeutic intervention altogether. With this said, you bring a very important point as well, which is the reverse of this. I think you alluded to it, or at least it was on your mind, if I'm reading correctly. And this actually was done by our colleagues in China, in Guangzhou, back, if I'm not mistaken, in 2018. They published it in JAMA Oncology, which is quite impressive work, where actually they felt that a local therapy plus systemic therapy for patients with systemic disease might be valuable. And that really was kind of like intriguing enough that now giving a quote unquote similar hepatic arterial infusion or chemoembolization version of plus systemic therapy might even affect the tumor outcome better, because of the value of controlling the tumor locally to enhance or control the worsening of the liver dysfunction. And interesting, I would say that yes, it might be applicable as well. For that reason, whenever we're in clinic, number one, yes, we bring those components per se, Number two, of course, will always enhance clinical trial. And number three, however, always will tell the patients, HCC is a different disease. Everything remains on the table. It's not like from stage 1 surgery to stage 2 to stage 3 local therapy to stage 4 systemic disease, and that's it. No, 1, 2, 3, and 4 all sit on the same table, or the therapies of 1, 2, 3, 4 sit on the table, and it has to be addressed individually for every patient what will be best therapeutic intervention, of course, with the help of the multidisciplinary team approach.
That was a very long answer. Thank you. Thank you. Thank you. We have prepared this presentation to be a little bit more practical. We wanted to show that, and we would be interested in how you would decide. It's a very recent case. We've just discussed that case in the Thema, and we would be interested in your opinion how you would handle that at MSKCC. I was quite astonished about the Launch trial, which shows that the ABC doesn't only go in one direction, but there's a 20% rate of downstaging grade C patients due to the combination of treatments, and to get them to resectability. I think there's a lot of music in that, and I know that there's an ongoing. It's an Italian trial. It's a prospective randomized trial comparing the Montanid now. Also to radioembolization. Also, there's a trial which compares the Embrace 150 systemic therapy to systemic therapy plus radioembolization. I think there's a lot of music in that, and there's also comparative data where they did a matched analysis of the SARA trial, which is a radioembolization trial, against sorafenib, and they put the interventional arm and compared these data, matched them to the Embrace trial, and they saw a similar time until deterioration of the patients in terms of quality of life. And I think putting these together, it's very interesting, but we are lacking the data. We're just lacking the data. So I just show you this patient. It's a 72-year-old male who has a history of C2 abuse, but he was clean in the last 5 years. He presented with a child A cirrhosis in a very good performance state, and he was resected of a lesion at the skull, where the surgeon first suggested it to be nephroma. I was completely surprised that the histology turned out that it would be HCC metastases, which with a high proliferation index, and then the staging was performed first by CT, which you see on the left side, showing that there was a subtotal invasion of the portal vein system of the left side, and in the MRI you see that even better, with a branch thrombosis even on the left and also of the right portal vein, and a diffuse tumor-like. You can see it in the late phase of the MRI on the bottom right, that there's like a subsegmental tumor dissemination within the left liver. And the CT was also a little bit suggestive of a peritoneal carcinosis interinterically. So this here was being rated also that there could be also peritoneal carcinosis. And so to sum it up, it's a diffuse HCC, it's stage C, but the AFP was 2,100, so really, really high, with distant metastases and also portal vein thrombosis. And I would like to ask you, but also the audience, how you would decide on that case.
So give us the options there, basically.
So I think sorafenib mono, you showed the data, it's not first choice now anymore. Would you go on levantinib in this case, or combination treatments, or no, apply apply immunotherapy plus VEGF inhibitors, or even maybe combine local regional treatments, revitalization or chemotherapy, or go for the model. This was a bone metastasis of the skull, bone metastasis of the skull, and as a diagnostic we had the MRI and CT scan, and have we done also PET? No. Okay, no PET.
Okay, so this, Ghassan, this is interesting. Perhaps I can say what probably most often is done in Switzerland probably would be a TACE since it's a stage C. But this will be the standard. But would you now, what's your thought on this? What would you, we can perhaps say afterwards what the two board has decided and why they have decided like this. We can tell that because the board are present. But we would like to hear your thoughts. What would you have done at Memorial?
Well, thank you very much. I have to say, sadly, these cases are real. We see them, you see them all the time. By the way, an important point here, especially for all of us, we already described and assessed the bone metastases that can occur in any bone in the body. There are too many of them, anyway. 25% chance for HCC to go to the bone. And skull bone metastases are kind of common. We've seen them many times. But I have to fascinate you before I answer the question about the case. The one that really was the most scary and fascinating, a patient went to their dentist for a root canal filling. And the dentist felt like as if he's drilling for the root canal. He's almost like touching the mandible and felt something really weird, does not look the normal mandibular tissue. He went ahead and took a biopsy and sent it to the lab. Turned out to be HCC. And later on, investigation, patient was found to have Hep C, but he never really diagnosed himself beforehand. Can you believe your dentist is kind of diagnosing HCC? Because it can go to everyone. It's incredible. So yes, does not surprise me. This is a classic case. At the same time, the options. Now we have stage 4 disease. So at least I'll start this way. I automatically, despite all what I said about the Guangzhou data, because we don't have evidence as a standard of care yet, I automatically will take out the lenvatinib plus TACE and the renal embolization, even though, to be fair, we just looked at the data together of the Launch study, and you can say, well, there's a certain outcome improvement per se here. It can remain as an option. On the other hand, I would say that sorafenib, lenvatinib, as much as they are really lovely options, short of a specific limitation why we should not get the patient any of the tyrosine kinase of the checkpoint inhibitors, then we use TKIs alone. But I don't think really anything you presented here will say no for the checkpoint inhibitors, let alone that the patient performance is more critical than age per se. As such, we're left with the atezolizumab plus bevacizumab and the durvalumab. Interestingly, either is okay. I'm not necessarily always very keen on the atezobev because of the 30% chance of anti-drug antibody that can neutralize the atezolizumab, rendering it ineffective and equal to sorafenib anyway. On the other hand, durvalumab, if you have access to it, by all means, it's an option and could be also considered. There's one more I might add to this, which is what about also a consideration, not necessarily a firm option, but pembrolizumab plus lenvatinib as per the phase 2 trial, despite that we're still waiting for the LEAP 002 study outcome. So I think the options are plenty. It's nice that we have options, but the Launch study positive outcome can give one option. Number 2 is atezobev for if people have no other access to, and they're going by the marketed data and not only with the concern about the things that are brought up about the ADA. Durva, if you have access to it. Pembro plus lenvatinib, of course, if you have access to. Sorafenib, lenvatinib, only if there's any contraindication for the checkpoint inhibitors, which was not presented.
Would you anticoagulate the patient?
That's a great question regard to anticoagulation. The PVT is not enough reason to anticoagulate the patient, and we don't. Actually, we have this study, we published it almost 20 years ago. We found that the chance for a continuation of expansion of a clot and even to have pulmonary emboli can happen with any tumor. And funny enough, that HCC had the least number of embolization that occur, like pulmonary embolus after a thrombus in any of the vessels. And biologically, they are from different mechanistic components. This is more imposition of liver dysfunction. And our routine is not to anticoagulate patients who have PVT or any thrombus in the portal vein.
So now you outlined really well all the options, but I'm really now curious to hear what would you have done now precisely? Which scheme would you have chosen?
So I'm in clinic as we speak, and let's say this patient is here with me in clinic. I probably will go for the durvalumab single agent based on great data, and to be fair, because I have access to it, because already it's approved for other reasons, and already I tried that exercise with the insurance companies and they were okay with it. And I know in Switzerland you have that kind of flexibility as well.
Okay, so yes.
Yeah, we discussed the topic of combining randomization also upfront, then with Umbruch 150. But in the end, we said we don't want to risk an impairment of the liver function due to randomization and not be able to give the first line therapy in stage 2. So we went to Umbruch 150.
Okay, so I think that's would be pretty standard here because we do not have access to the Januar, and also because the phase 3 is really kind of data is really quite intriguing despite the antibodies, because the antibodies are media there, but despite these antibodies, they had this effect on progression period overall survival. So this is still valid in a sense, although there is some things which work against it.
I mean, the other thing that the hepatologist has to throw in here is that people usually don't die from bone metastasis, but what patients, at least to my experience, really die from is, eventually deterioration of liver function and liver failure. I don't know whether you agree, but that's at least my hepatological view of that problem. So I think controlling disease in the liver is really key for, prolonging life in these patients and taking care of the liver in general, not having too many side effects that will then eventually affect overall liver function, probably the other important aspect.
I like your argument, and to be fair, I already referred it also in the data that I referred to from Guangzhou, and this is the argument that he had. Actually, funny enough that I know that Jordi Bruges has been talking about this for a long time, about that you have to take care of the liver because this is really the organ that really will be most affected by the dysfunction. And exactly as you said, you don't want ever the cancer to become sitting in the back seat, and you don't want the liver dysfunction to be in the driver's seat. Interestingly, I'm a big fan of that approach, but we are not there yet on the practical level to produce this activity in the US. But I know it's coming because with respect to the privacy of the discussion, I know that we have some exercises of that nature, hopefully coming into clinical trials soon, but we're not there yet. But the concept, I like it. And yes, you're right. It could be at least worth investigating further, see what we can do with it.
Just to comment on that, there's a subgroup analysis of the ceramic trial assessing the prognostic factors of extrahepatic disease. And the only metastases who had an impact on survival was lung metastases, no bone metastases. And then it adds up to the microvascular invasion, the tumor thrombus, which is, so to say, the definition of child C. And there, I think this has been proven without a doubt that the extent of the tumor invasion in the bone vein is very important to consider the dismal factor.
Okay, thank you. So further, perhaps I'd like to have some kind of statements from you towards the end. I come back to that, but I'd first like to ask others if they have questions from. One more case. One more case. So let's go to the second case.
It's going to be a very, very brief case. This has been a young.
Wait.
It's not shared. I can start talking and then we can look at it later. So this has been a young lady who's been in my hepatological care for quite some time because she was from Hong Kong and she had a known chronic hepatitis B, businesswoman, very active, traveling a lot. And she decided that the whole surveillance business was kind of annoying. And at some point decided to drop out of my regular 6-monthly surveillance. Also because her liver function was pretty good. She had, a FibroScan of at the time, I think 7. So we said it's probably not very advanced fibrosis. And then I get a phone call in October 2019 from her. She's just traveling and she just had a checkup in Singapore. And they found a large liver lesion, segment 7-8, which at the time of this CAT scan was about 8 to 9 to 10, almost 10 centimeters. They classified this just by the imaging as a BCLC stadium A hepatocellular carcinoma. Very, in line with that, the AFP at the time was 103,000 micrograms per mil. And then she came back like on a red-eye flight to Zurich because she said, I want to be treated where I will know the clinic best. So she came back, we presented her to the surgeon, and she received the right hemihepatectomy basically the week after she was diagnosed in Singapore. At that time, it was a PT1BG2V1, so vascular invasion tumor. And what we planned at the time was to include her into the ongoing keynote study, which was adjuvant pembrolizumab after resection, because she seemed to be tumor controlled, tumor free, and we thought she can have this adjuvant treatment now for a curatively treated HCC patient. So that was, and that was usually animated, but I skipped the animation. So that was her all the way to the left. AFP 103,000 rose to 113,000, received her right hemihepatectomy on November 5th. And then we were kind of scanning her AFP because she had to go below 1,000 to be eligible for the keynote inclusion. Or I think was it below, so she had to be below a certain threshold, and she never reached below that threshold. So we kept measuring her week to week, and unfortunately, on the already in January, so roughly 2 months later, she was diagnosed with an early new tumor in segment 2, which was then a week later resected, and she received the second resection, segment 2. Her AFP unfortunately kept up at a level of about 1,200. And imaging was performed again, also PET scan, and we found a bone metastasis in the eliminative rib. So all of a sudden, this 48-year-old woman who was intended to be curatively resected was now a bone metastasized HCC. And as this was very much in the wave at the time, she was, obviously discussed in the tumor board and then started on Imbrave-like protocol at Tisobev end of February. There had been some discussion. She wasn't too convinced she wanted to do immunotherapy. We gave her the tumor board advice. She was starting on that. And all of a sudden, right after she had the immunotherapy started, her AFP started skyrocketing again. And she ended up at an AFP of almost 50,000 under the ongoing immunotherapy. At that time in April, we stopped Tisobev, started her on lenvatinib, and she dropped with an AFP to 7,500, which then, and again, imaging, there was an impression that it was diffuse infiltrating disease on the rest of the liver, where she received a CERT at the end of May and reached an almost, lowest level of 313 AFP. Then started slowly to rise again. And, after another discussion, and I just lost my image. After another discussion with the tumor board, she and then she received another, discussion with the oncologist, received another round of Ipi-Nivo now, which was available at the time, stopped and started Ipi-Nivo, and again, skyrocketing AFP values to 80,000. So I thought this was an interesting case. Unfortunately, the lady then had to stop Epinemo because of side effects and deterioration of the liver. She actually never really recovered from the SIRT and had, severely impaired liver function, basically from the time of the SIRT on, which then deteriorated further with immunotherapy, and unfortunately, the lady passed roughly a year after she was diagnosed. But nonetheless, I thought it was an interesting way, or an interesting reaction and case where it seemed that every immunotherapy cycle led to a massive increase in AFP and probably tumor activity. So I think there's something in it for everyone.
So, Ghassan, your thoughts on the case?
I have to say, I'm very grateful that you present this case. This case is fascinating in every way, and it has a lot of learning points and teaching points that are very critical for all of us. Number one is the issue of the alpha-fetoprotein. And I am very happy that I didn't see any of you reacted. Good for you, because interestingly, we know that hepatitis B can cause very high alpha-fetoprotein and tumors are resectable still. And it's good that we don't react to the AFP as if it's like a guidance for the therapy. i.e., if any of our colleagues, same like this patient, call me from Hong Kong and say, I have a patient with alpha-fetoprotein is more 500,000 and I'm taking surgery, it's okay. On the other hand, if I, for example, say I have a patient with Hep C and with AFP only of 50, but the patient has stage 7 disease, that's okay too, because AFP does not go high with Hep C, same as it does with Hep B. So that's a very important point here. Point number two, the surgical intervention was, of course, no surprise, impressively done when the patient came to Switzerland. Understandably, the recurrence, this brings a very interesting point. We, if you recall, have a paper from the era of Leslie Blumgart here at Sloan Kettering, and from when Human Fong were here, the 1,001 patients. And interestingly, the understanding is that there's a recurrence that sadly, still despite all the best hands in surgery, if there's a recurrence of HCC, it's treated as a stage 4 disease, because the outcome of patients with recurrent disease is as bad as it is for stage 4 disease. That's one concept. On the other hand, despite that all of us spoke about the combination therapy or adding things on, but you hit it right on, and this is exactly the teaching point, that sometimes, surprisingly, after local therapy, things get worse rather than better. There was a very well denoted experiment that happened at MD Anderson a while ago. It's published in the literature, where they did preclinical work in mouse models. If you happen to have a tumor on the left side of the liver and another tumor on the right side of the liver, if we were to embolize the right one, guess what happened to the one on the left? It increased in size and increased markedly. Actually, not only that, but they went ahead and measured the VEGF to see what will be the enhancement of the tumor, same as we've been really learned about angiogenesis of tumors for a long while ago. Interestingly, the VEGF level went up after the embolization by 1,500 times. Wow. So you can imagine, in other words, you really cause more disease by simply causing a good intended or well-intended local therapy. And as such, you might have, in retrospect, say, maybe I should have started only with systemic therapy. But nonetheless, this patient ultimately what the patient got anyway and got the therapy. And the last point that I would like to bring up, which again, I give credit to you as well, is the understanding that we tried the atezolizumab, it did not work ultimately, we changed to lenvatinib. This is the concept that I brought in back in 2020 at the TAC meeting in Park City, Utah. This before the start of the pandemic, probably it was the last meeting I was in person. And at that time, I brought in the concept of line -1, where in other words, the atezolizumab is not enough to say, okay, that's it, move from atezolizumab directly to, let's say, to cabozantinib. I think, to be fair, the lenvatinib sorafenib has still important assets, and that's why we consider the atezolizumab as line -1 and still will use the TKIs in the same sequence as we have them as well. I think these are the important points that I would say are very nicely delineated in this excellent case.
Okay. Okay, thank you very much. So this is so exceptional case, I have to say, really, really strange, but interesting and further points from the audience. On the Zoom, perhaps, or we have here Jan, what's the question?
I haven't heard much about surgery yet. Stage 4, you know, this is rather a disaster most of the time. Could you outline a typical surgical patient with and without cirrhosis? And the second question is, how do we balance microwave ablation and limited resection?
Sure.
How do you make the decision in your patients?
You know, thanks so much for the question, and you're right. We should be more fair to everybody. But no, your point is well noted. To proudly tell you how we function at Sloan Kettering, because I think it pertains how we function. Interestingly, today is Tuesday. I'm here where I am on the 4th floor. Believe it or not, right underneath, immediately on the 3rd floor is Dr. Jernigan, who is the head of our hepatopancreatic surgery. And this was on purpose. We do our clinic on the same day, because this way, if we feel like there's any direct input needed for either of us to talk to each other about a case that's either resectable or potential resectability or what have we do that evaluation. In general, all cases, because as we know, the cirrhotic component short of the liver function test is really now showing a advanced B stage or C on the child pew. By all means, if it's a surgical potential resectability, it deserves a chance to be looked on by the surgeons. Now, in regard to the RFA, radiofrequency ablation, I would say our practice has remained limited at Memorial. Why? I'm not sure, but to be honest with you, this become a little bit more operator dependent. And I know that other places have done more of this than we have done. And you know, some of them do it, even some of them subcutaneously, and others do it as an intervention. But there's nothing really particular why we don't or we do. But of course, it's another option which has the same survival outcome as surgery as well for the small micronodulous tumors, as you said.
Okay, thank you. So, further questions? At the moment, just I'd like to just one statement. Would you now consider the combination of TACE and then based on the Launch trial, the new standard of care, or something one would have to really now consider in every case, or do you think that's more like in some exceptional cases? When you think about TACE, do you think that should be really offered to the bulk of the patients in general, or do you think it's rather an exceptional thing?
Sure. So thanks. This is a very good point that I would like to bring from two perspectives. Number one, for the patients with only local disease in the liver, I'm intrigued by the up to 7 criteria that Dr. Kudo has shown us and shows that probably systemic therapy can be helpful. But on the other hand, the other thing that I would like to bring up is exactly the point that was touched on by the Launch, which is local plus systemic for systemic disease. And I have to say that I've been really quite fascinated by this from the time of the data has been reported even in China. And no doubt that it has an opportunity. I would say that, and I promise you that because I try to be diplomatic by saying we don't practice it, but definitely you definitely made me jolt down over here that we'll discuss it a bit more internally, how we can really start looking into this, either as being, as you just mentioned, a standard or even as part of potential clinical study or clinical trial per se. With this said, you bring a very important point as well, which is TACE versus what we do at Memorial, not necessarily that I'm trying to promote it, bland embolization. And funny enough that as much as we promote bland embolization for all our therapies when we do local therapy only, but however, when we are combining it, for example, with a checkpoint inhibitors, question mark also with tyrosine kinase receptors, I think a chemoembolization might be more valuable because simply of the triggering effect of the doxorubicin or what else you're going to give as chemoembolization therapy to enhance further the effect of the checkpoint inhibitors or TKIs. So by all means, is worth looking into. And if anything, this is what I kind of, since we discussed before the meeting and now at the meeting, definitely you're triggering our curiosity quite a bit about the Launch study.
Good, great. The last question, we also often discuss this question also where Oliver is now really intensively involved, is the SEERT question. Do you think SEERT, because ceramic was negative, do you think that this is an exceptional case? So in which cases do you use SEERT? So the radioembolization.
I'm sorry, I did not repeat. So the question is about embolization. I lost one word. Do you mind repeating?
It's about radioembolization. So because it's still, not in the guidelines really, it's always a TACE or planned embolization. So when do you think the radioembolization is really something much?
Sure. No, that's again an important point. So we have to remember one thing, that the agency, at least the agency in the US, which could be differing in other parts of the world, will treat the local therapies like radioembolization, bland embolization, chemoembolization totally different from the way they treat systemic therapy. You don't need to randomize trial. They actually approve that this intervention is safe, does not hurt people, but you are not really obligated to show an improvement in survival in any way. So it's a different path at all for the FDA. And as such, radioembolization, same like embolization or chemoembolization, is there on the menu that can be used. The best read that we have seen from our colleagues that whenever a chemoembolization is not applicable where there's a vascular involvement, where radioembolization can do still their effect, could be applicable. And this really in general what has been defaulted as being the accepted nature of when we do radioembolization. However, it all depends who is the operator and how experienced they are. Because for example, I'll tell you, if the best expert of radioembolization is really the only one available, of course, I will not ask them to do a chemoembolization or vice versa. And for that reason, it's a little bit operator dependent as well.
Okay, thank you very much, Ghassan. This was really helpful. And I'd like to thank also the co-moderators and the sponsors who helped us to support this meeting. So thank you for joining us. You will have your day in front of you probably, or in the midst of the day. So we'll have the dinner now. We'll finish the dinner here and we'll enjoy the evening. So thank you very much for joining, and thank you everybody for joining also here. Thank you.
Oh, thank you very much. Can't thank you enough. And the only request I have, make sure next one is in person. Can't wait to see you all in person.
Thank you. Bye-bye.
Bye, everybody. Thank you.